Hi everyone, my name is Lucy Braid, and I'm going to be sharing with you the qualitative work that I did with Columbia University Medical Center as part of my summer internship. Our study's goal was to examine community perceptions around current sugar-sweetened beverage interventions aimed at the first 1,000 days, as well as to learn more about the potential barriers and facilitators to implementation. I want to start by defining some of the terms I'll be using. First, sugar-sweetened beverages, or SSBs, refers to beverages with any added sugars, such as non-diet sodas, sports drinks, fruit drinks, etc. And these are of major concern because they're the primary source of added sugar in the diets of children and adolescents and can lead to a host of negative health outcomes. Second, the first 1,000 days of life refers to the period from conception to age 2 and is recognized as a critical period for development. The first 1,000 days are when a child's brain is beginning to grow and develop, and when the foundations for lifelong health are built. The reason our study focused on the first 1,000 days is because poor nutrition during this time can cause irreversible damage to a child's growing brain and can increase their risk for obesity later in life. Among infants, approximately 14 to 26% consume SSBs during the first year of life, leading to a twofold higher odds of obesity at age 6 compared with counterparts with no SSB intake. Maternal SSB consumption during pregnancy can also increase risk for offspring obesity during middle childhood, and therefore we wanted to better understand what helps and hinders pregnant women in these communities when it comes to eating healthily. While poor nutrition is a concern across the socioeconomic spectrum, we see that low-income communities are disproportionately affected by its adverse health effects. For this reason, we focused our study on Washington Heights and the South Bronx, as these are two of the poorest and consequently unhealthiest neighborhoods in New York City. Both are predominantly made up of Hispanic and non-Hispanic Black communities, which have the highest rates of consumption, and both have a high prevalence of childhood obesity. Once again, the objective of this study was to investigate community perceptions around current SSB interventions and to better understand the barriers and facilitators to future implementation. We did this by way of semi-structured, in-depth interviews that asked interviewees about their perceptions of various micro, meso, and macro level programs and policies. On the micro level, we asked about community-based programs that help to support healthier purchasing. On the meso level, we asked about wellness policies, such as Article 47 of the New York City Health Code, which bans SSBs in federally funded childcare facilities, and the Healthy Kids Meals Bill, which mandates that water or milk be the default beverage served in kids' meals. On the macro level, we asked participants about citywide legislation, such as the soda tax. In total, we interviewed 19 community leaders and community members from Washington Heights and the South Bronx, identified themes, developed a code book, and used in vivo to code all interviews. We employed immersion crystallization techniques for interview analysis. Our most significant finding was an almost universal belief that integrative approaches are necessary to make lasting impact. Many participants stressed the importance of education, but argued that education alone is not enough. While community members and leaders were both in strong support of legislative policies as the most effective strategy to reduce SSB consumption in the first 1,000 days, their perceptions around barriers to implementation differed. According to community leaders, the main barrier is lack of community support and buy-in. Community leaders also expressed concern around issues of equity. According to community members, on the other hand, the main barriers to implementation are lack of access both to healthy foods and to nutrition education, lack of awareness of community programming, and issues around addiction. So what this tells us is that approaches that incorporate community buy-in, education, and accessibility will likely allow for more successful implementation of SSB interventions focused on the first 1,000 days. Community members and leaders believe this type of approach will yield more significant reductions in SSB consumption among pregnant women and infants. In terms of next steps, these results highlight the need for further research around barriers and facilitators to SSB interventions in other low-income urban neighborhoods. Childhood obesity rates are continuing to rise, and these neighborhoods already face a disproportionately high risk for chronic disease. For this reason, it's crucial that we develop more targeted and effective interventions and continue working to reduce the health inequity that plagues our country's most vulnerable communities. These are my references, and I just want to give a special thanks to my PI, Dr. Jennifer Wubadal, my faculty advisor at UC Berkeley, Dr. Chris Madsen, and my entire 2020 Public Health Nutrition cohort. Thank you so much for listening.